Hello, welcome to the video. This video will be talking about the pathophysiology and pharmacology of Parkinson's disease. So first of all, we will look at the overview of pathophysiology in Parkinson's disease. It is mainly occurs in the basal ganglia of the brain. The dopaminergic neurons in the substantia nigra started to die and lead to less dopamine. And dopamine is the factor that enhances the precision of our movement. As we can see from the picture, the issue that we have here is the neurotransmitter, not the receptor, as the neuron is dying and cannot release as much dopamine and lead to abnormal movement. Moreover, the overstimulation of the neuron is caused by the imbalance of acetylcholine and dopamine. Acetylcholine is an excitatory neurotransmitter that causes cholinergic activity, and dopamine is an inhibitory neurotransmitter. According to Heckler et al. 2022, Leo 2022, and in Parkinson's disease, the amount of dopamine is less than acetylcholine. Looking into more details, when dopamine decreases, it does not bind to the D2 receptor, which inhibits the GABAergic neuron, leading that GABAergic neurons become overactive and secrete GABA, which inhibits the GABAergic neuron in the globus pallidus externa. And as it is inhibited, it cannot inhibit the glutaminergic neuron in the subthalamic nucleus. And so, the glutaminergic neuron will secrete glutamate, which will stimulate the GABAergic neuron in the globus pallidus interna. At the same time, because we don't have enough dopamine, the dopamine does not bind to the D1 receptor. Therefore, GABAergic neuron that inhibits the GABA in the globus pallidus interna is not activated, and consequently lead to an overactive GABAergic neuron from the globus pallidus interna to the thalamus. As a result, it is excessive inhibitory input to the thalamus. Thalamus inhibition causes suppression to the thalamus corticospinal tract, making the signals from the basal ganglia cannot send back to the cortex. This is the explanation for the uncontrolled and uncoordinated movement. Harry et al. 2021. And now we'll be moving on to the pharmacology of levodopa. Levodopa is the common drug used for Parkinson's disease, which is a dopamine precursor. Levodopa can go past the blood-brain barrier, which dopamine cannot, and go into the neuron. In the neuron, levodopa will be converted into dopamine by carboxylase. As the dopamine increases, it will reduce the effect of Parkinson's disease. However, the effect cannot be eliminated. Moreover, levodopa should not be administered by itself because it will be broken down by dopamine carboxylase to dopamine. Therefore, if levodopa is converted into dopamine before entering the brain, it will not be effective. So levodopa will be used in conjunction with decarboxylase inhibitor, which is normally known as carbidopa. It will prevent the breakdown of levodopa in the peripheral area. Note 2019. Besides that, it is also important to remember that this medicine might cause nausea, vomiting, or dyskinesia. And when the patient is taking levodopa, it is crucial to educate the patient and be mindful of not taking any MAO inhibitor, as it might cause unexpected hypertension, and not to consume food and beverages with high protein, as dopamine and protein have to complete each other in the small intestine in the body, and the excess protein will take over the levodopa, which will decrease absorption. According to Australian Medicine Handbook 2024 and MIMS Australia 2024. Based on the function of the drug, we can see that Levodopa is the first-line management for Emma in her Parkinson's disease. Thank you for listening. This is my references.